So we should have now a block of lectures, but because Peter Neuschel, as I mentioned, cannot come here, and he's on Homolka, he wants to show us some case. So I give him now room for showing the case,
Peppo,
and then we will
Peppo,
continue with the lectures.
Okay, Peppo, can you hear me? So
Yes.
actually, I just minimized my basic presentation for the BTL technology while we are going for this very nice patient, or very dangerous patient with storming, okay? So you got the storm just during the night, okay? So if you give us like some minutes, we'll be more than happy. So first of all, I will talk about this BTL company which developed catheter which is named EasyPulz, and this is the first.
But we see picture from the lab. So
okay. Can you switch the presentation?
Yeah, that's a presentation.
Okay, fantastic. We got it. Okay, they are a little bit they're a little slow. Okay, like, after the party. Okay, so so this is the first clinical experience with this catheter, which we did the first in man patient November last year, and actually I'm proud to show you the first results. So the catheter is designed to be single shot. Okay, so we were speaking this morning about the single-shot technology as nanopulse, and this catheter is equipped with, multiple electrodes, like 32 electrodes, in say like 3 rows, and the diameter is like 33 millimeters in max. And actually, it's very interesting that even in the collapse fashion, which is 8 millimeters diameter, I can show you this collapse catheter, you are able to deliver the pulse. This is very important, that actually it's no any arcing, even any other like funky shape, you are really be aware not get any arcing, as we know from other like pentaspline catheters and maybe others, okay? So the biphasic pulse is designed to get more than 2 kilovolts optimized for the catheter, and the pulsing is going from all these elements. So the PF train delivery is like in total 10 seconds, because after 2.5 seconds application, there's some pausing, because actually the engineers really want to avoid overheating. So this is again the same. So I will, because in shorter time, so we can skip this. So we did a lot of preclinical experiments during 2021, 2022, and actually we have survival animals. I will show you in briefly just the catheter shape in two main fashion. It's like basket shape and actually disc shape, and as we can use even the collapse catheter. So actually for maybe linear lesions, I don't want to stress this. It's too early to speak about it. So we got really good results in the animals, not only just acute results, but even chronic animals, okay? They're like remap 5 weeks after. And actually we spoke about all the thermal effect, because we need to admit that a lot of PF technologies can get really somehow even borderline thermal effect for ablation. So we did some very nice scenario how to apply like max application, and we couldn't access the 40 degrees of centigrade. So this is the study I would like to show. So the design as a first-in-man feasibility trial with even the remapping of all the patients. We put all these patients IRR, so both they have remapping and they have even the LRRs implanted. This is the one example actually, as I spoke about, 10 seconds pulsing, which means 2.5 seconds and then pausing. So we can render the catheter based on any mapping system, but we used Carto for all these the shadowing things, and you can see for PVI, we didn't do only PVI, but for PVI you can appreciate the positioning on the fluoro. So for each vein, we apply at least one application in the basket shape and in disc shape, like out to the vein. This is an example. I will skip it because we will have live case, so I can skip this. Okay, so the results are very encouraging. The acute effect is very good for this patient cohort. Total procedure time, despite all this pre-mapping, mapping afterwards. So it's like, around like some like 1 hour, and actually total fluoro time is like 6.8, and procedure fluoro time is 4.2 for the ablation. So this is the results. All PVs were isolated acutely. The lesions per vein, because I mentioned the single shot, but we deliver even more because we would like to cover the anterior part of the right and left superior veins mainly. So we apply up to 6 applications per vein, and we did some application even for posterior wall with the disc shape, and this is like 7 up to 9 applications. So this is the posterior wall strategy, how to apply, and you can see on the Carto and the fluoro disc, and then the Carto, the application set. So we have excellent safety profile of all these patients, and right now we are proceeding the remapping for all these patients. They will get this 3-4 months procedure whenever they have atrial fibrillation evidence or not. But as I mentioned, we have excellent monitoring system in the implantable sub-Q EKG. So I think we are waiting for this remapping studies, and hopefully we'll be able to be back in 1 year with much more robust data. Okay, so Peppo, thank you for giving me the chance to present this in briefly. And if we have a time, I don't. It's up to you.
We have 10 minutes time because there is a lecture from Lübeck and then from Split,
Yeah.
so we cannot postpone it.
You
have 10 minutes now for anything.
Now, so we will have like live case instead of presentation. Okay?
You can come back later, but now you have 10 minutes for live case.
I know, I don't want to go later. Okay, let's go for live case. Okay, perfect. Thank you so much. Guys, can you switch to the live case?
Almost. Okay, let's check the RF.
Yes.
You want me to do it now? Okay, ready? There, it's working. We're live?
So Vivek, 10 minutes.
Yeah, hey. Yeah, wait, 10 minutes?
Yes. You can come back later, but we
No,
have
I think we're good. Let's induce me.
transmissions from other places from abroad.
Okay, no, I think 10 minutes is good because I have to go catch on my plane. So we have sort of an unexpected case. So there's a patient who has a history of dilated cardiomyopathy who, I don't know much more about him. Ejection fraction is reduced, as you can see from the echo.
There was 150 ATPs during class.
Yeah, so he had a lot of VT and 150 ATPs. As you can see actually on the running screen, he actually has a wide complex tachycardia. It's a slow VT. He's on amiodarone, right? Yeah, I think he's on amio. So you can see it's a very slow VT. It got slower and slower with more amio, but it sort of keeps on going. Oh, and there it's back. And we're going to induce it again. So because of that, we decided to, bring him to the lab. What we've done so far, if you look on fluoro, we have a transeptal sheath. We have actually a catheter in the CS and almost the AIV. And now actually the VT is, of course, it's a little more difficult to induce, but it's gonna come back pretty quickly. So why don't we show them on the review screen, there it is. Let's just show them on the review screen the VT. So do you see the review? Make the review big for them, please. And show a 12 lead. So go to a 50 sweep speed, maybe. You can see the VT, the QRS is relatively wide. Notice that it's positive in 2, 3, and F. Not severely positive, but more positive than negative. It's left bundle, and it looks like it's coming from the base. I mean, in a dilated cardiomyopathy patient like this, it's not surprising. It'll be coming from a perivalvular region. Also note, not much notching on the QRS. I don't have this base. We can even look at the baseline. There's not a huge amount of notching because you're not going to get a lot of scar in this case. Now, let's show the electrograms on that review screen, that same one, because I think that if you scroll down to the electrograms, notice, and go to 100 sweep speed, please. 100 sweep speed and unclip the CS. Notice that the earliest actually is around the CS. So when you have these perivalvular sort of substrates, I like to put a CS catheter in because then you get a pretty good understanding of the base. And you can see it's relatively early in the CS. Let's just drop a line on the CS1, 2, or 2, 3, or whatever.
It's not earlier, I think. Well, a little
What's that?
bit.
Yeah, it's right around the beginning.
Yeah, a
but
little bit.
but it's not surprising. It's near the exit, probably at the exit. Now let's focus on the Affera screen. Well, we can show the whole screen, please, all the screens, and let's go ahead and induce tachycardia. So we induce tachycardia, and let's just show them where it is. Show an RAO and an LAO view, please. Yeah, now we're in VT again. Show RAO view and LAO view. Okay, if you look in the RAO view, you see the earliest point here. So let me just try to get my catheter back there again. So, and what was really interesting is there appeared to be a mid-diastolic potential here. So if I can get back to this location, you can actually see it. Do you see that potential, Joseph?
We don't see it. Can you enlarge the screen?
Right about
from
here.
Pruka? So it looks like upper septal arrhythmia. We had recently a very similar case like that.
Yeah, I mean, I think this happens very, very frequently. And I think one of the nice things about this catheter is that you can see these small potentials. So I think that's real.
For
now,
the audience, a big screen, running screen, the Pruka, just to see the mid-diastolic because it's very
can
tiny
you show the
here.
running
Okay,
screen,
perfect.
please?
Perfect, now it's...
Yeah, and the occasionally that you can see an atrial spike. You see there on the atrial spike on the green.
Yeah.
So that's the atrial.
Can you do entrainment from this D3?
Well, I was going to do something better. Well, we haven't done it yet because I was worried that.
Yeah, that would
we
be
wouldn't
nice.
Well, no, but I was actually. I want to do a. No. I want to do a reversible pulse actually from here.
Reversible pulse.
Let's see if it works. So we haven't tried it yet. What's that?
I will do entrainment.
Let's do reversible pulse. I really want to do that.
It's your business.
Just before
Okay,
you do it,
let's go.
Do you know where the HISP is? This a BIV device?
It's nearby. But
No, he needs a
patient
BIV.
is-
Yeah, you haven't seen the baseline QRS, but he definitely needs a BIV. We already talked about that.
Okay.
That's going to have to happen. Because his wide QRS is what? It's like very wide. 150 or something. I don't know.
It's not that wide.
No, but most of the time he's actually paced. So what happens is when he has atrial pacing, it ends up also being ventricular paced.
We are ready for irreversible.
Let's go ahead and do the reversible pulse, please.
Okay.
Let's see how it goes. Oh, what do I do? Do I step on the pedal now?
Yes.
Okay, here we go. Let's see. Well, that didn't do much.
See, nothing happened. That's what I expected.
Let me do one more reversible. Maybe a slightly bad location.
Just my comment about this is that for the VTs, the reversible pulse is difficult because it's usually deeper terminate.
Look.
So can you just during the sinus beats?
Of course, right as you said that.
Just for
notice that right as you said that it terminated with the reversible pulse.
But it terminated before. But do you know we're doing the sinus rhythm where the hiss is?
It will terminate
let's go
by
ahead and
pulse.
induce tachycardia, please.
Come on.
And we can do an entrainment attempt. Is that what's wait? Oh no, Chief, it had started.
Induced.
There we go. There. Oh no. Okay, induce again, please.
Induced.
You can see there's a very late potential. I mean, it's extremely late at that location. Okay, there. Is that going? Yeah, that's going. Okay. All right. Let's see if let me see if I can find that potential again. It's really tricky. I think it's there on D3.
Oh, it's terminated again. So when you touch your mate, so terminated.
Maybe. The problem is it is a bit finicky now.
Okay.
What is a signal in sinus rhythm? What kind of signal you can see there?
You see a late potential. Stop pacing for a
No,
second.
we don't see it.
Okay, look, you see it there now?
You can see the light, very light.
Yeah, but it's
Absolutely.
spaced. It's spaced beat, so it's a
No,
retrograde.
no, no,
Can be a
not
retrograde
paced.
conduction
It's not
system.
paced.
I think that is
No,
a
no,
conduction
you're paced.
system.
Fine.
So-
Can you prolong the PQ for the device to see the normal spontaneous activation and normal conduction system?
We can do that.
You can do VVR for it.
No. Just prolong the AV interval. Let's put the AV at whatever, the maximum.
Like maximize
I don't know
AV.
how much he conducts,
conduction.
actually. But I'm not sure it makes that much difference.
You have VVI? Oh, they
No,
have
no,
VVI.
Chief. No.
No,
Put
AV.
DDI at like 60 or 70 with
With
a very
crazy
long AV interval.
AV conduction.
Can we see the main screen running signals?
Yeah, we can go to the electrograms, please. PRAGUE screen. What's the AV interval now?
Pacing from ventricle.
Yeah,
Now.
hold on, guys. We're good
They
here.
are working on that.
Yeah, he's going to keep pacing. This is the problem. With as much amio as he has on board, I think it's going to,
Yes.
unfortunately. Okay,
Can
let's
you
go ahead and
pace map from this, from T or from D2 or T3?
Yeah, we can do that. I got 15 more minutes. Let's pace from
okay.
T1. Let's pace from the tip, please. T1. T1 or D2, either one. Let's try. Ugh, it's not capturing. Max output.
That's a problem with this
Yeah.
electrode that often you cannot pace if there
Can
is
you
a
Okay, let's
small...
pace from the whole
From
thing.
all?
signal.
Can you pace from all?
Yeah, let's pace from the whole template.
With nothing.
Jesus.
Nothing. Okay.
I forget it.
Okay.
Okay. So I think we'll...
Maybe my contact is pretty bad. Give me a second. Let me try to improve the contact here. This
The
is one of the
signal is not
problems.
crisp anymore now.
No, it's not.
How much time we have, Peppo?
Oh, well, we should...
2 minutes?
we should switch to Liebeck now.
Okay, fine.
Well, do you want to wait until we deliver energy and see what happens?
Okay, but...
Okay.
Or you
Yeah,
can go.
we
You
can
come back.
we can delay maybe a few minutes, 4 or 5 minutes. Oh, you see
Okay,
now
no,
pacing.
stop.
Okay.
No, I don't think we capture it. I think we just show me the
Send you induction.
initiation of that for a second, please.
Here?
Yeah, I want to see the initiation. Show me the electrograms also. Okay, so the very first beat almost certainly captured. After that, it was garbage. So let's look again at the 12 lead here.
Yeah, it's
So that
beautiful.
first beat is pacing. The
Yes,
next beat is likely
it's a VT.
tachycardia. You see that? So it looks pretty similar.
Yes, very
Okay,
good.
let's we're in tachycardia. Okay, so
Okay.
set it to RF, please. Here. Yeah.
We
Petro,
see
RF,
the
please.
signals.
Okay.
Now, normally I'd be very worried about the AV node
you
here,
get
but
on the
we know that we're going to cause.
some Pruka?
So normally,
Yes, perfect.
so normally I'd obviously be worried about the AV node here. In this case, we know that we're going to upgrade to a BiV. We know that he's already paced most of the time anyway. So I'm more worried about tachycardia than I am
Nice.
about AV node here. Are we
You,
set to
based
RF?
on ice, you are
RF.
below the right cusp.
RF, we are
so
RF.
it should not be
We-
his.
We are ventricle RF, okay? For ventricle.
Yeah, I think I
So if
don't
you
think
have
my
there-
contact is very good. Yeah, I 100% agree. I think I'm a little bit above where the hiss
yes.
is anyway, where the AV node is anyway.
Okay?
This is again what I was saying yesterday. We need better sheets to do ventricular mapping because it's really difficult. to position
That's what
this.
I'm saying to all companies for many years. Nobody listens.
Nobody cares.
VT is not the big business like
Yeah.
AFib.
Only
It
physicians
should be,
care about VT.
no, Beppo is wrong. It should be big business when we have
It should
good
be, but
catheters.
it's not yet.
Okay, let's start.
Go. It's not specific. It's not.
I just think it's.
A little slower, but not really.
See, Mike, look at the temperature. It's not reaching.
great. Oh, it's termination late.
Yeah, but it's
termination.
poor contact is the
No, it's
problem.
poor
Rotate the image more RAO, please. Not this push right loud. Yeah, good, perfect. We're gonna need to. We need to get a better contact. See that if you look at the blush, the thermal blush is pretty crappy. Yeah, even during pacing, we didn't get good contact. Yeah, he was just pointing that out. I think I have a better contact now. Look at this. It's actually much nicer. Let's do another lesion right here, please. And then we should try to induce again. This obviously has been a temperamental VT.
It's not great, right?
Oh, good. I'll be able to catch my flights.
Okay, no, it's perfect. It's good.
So, we're talking about sheets and the fact that we have bad sheets. There are things you can do, like the transeptal puncture. We try to do it as anteriorly as anteriorly as possible. Number two, we use a long curl sort of sheet, so that way we can try to counterclock as much as we can. Try to induce again, Chief.
And with induction, we can leave, right?
Yeah. No, see, it's still going. We still have to. We just have to. It's a little weird looking, but yeah, it's still there.
It's still
Yeah, you can put 60 seconds. But, I mean, the
same.
reality is we need to get good contact here.
Okay.
This is.
Okay.
Yeah, I want to try. Yeah, we can try to. There, that's nice termination.
That was beautiful.
It's much better.
Yeah, that's much
Yeah, it
more
was
like
immediate.
Yeah, that's very nice contact. Yeah, agreed.
It's very specific to this pure
But I
contact.
think I really like
Yes.
this Sphere 9 for these perivalvular substrates. I think it works really well at being able to map with these small electrodes.
These
The
patients
problem,
with
of course, is positioning.
dilated cardiomyopathy, sometimes you can also ablate from right cusp, and there is still some slow
Okay.
conducting
Can we-
tissue around.
can we induce,
so
guys? Can we
it
induce?
is sometimes advantage to go
induction.
retrogradely.
Do induction.
I never ablated with Sphere 9 in aortic
Induce.
cusp, but
Induce, guys.
it might be also possible.
Yeah.
Veď co tam dělají?
Hold on, I think my RV
Okay,
cap
guys,
is up.
we have to move to Lübeck, so we can
Okay,
come back
well-
to you after presentations, and you can give us final,
Yeah.
let's say,
Many
update
thanks
of-
to
of the
give us
case,
the
okay?
chance, okay? Many thanks. I
Can we
appreciate it.
switch to Lübeck?
Thank you.
Yeah, it's slightly.
Hello, everybody.
Roland?
Hello, everybody. Hi, Peter.
Hi.
Hi.
We
Hi,
are
Ron.
here both with Peter and myself. So it's nice to see you, and you can have now presentation. Sorry for a small delay, but Peter Nogel had some acute case, so he wanted to show us on live.
That's excellent. I have seen a wonderful case and a wonderful presentation. So thank you very much for inviting me. I'm very excited to share my experience with the Volt balloon. So what is special about the Volt balloon? The balloon, it's a novel balloon in basket design. And I think this is unique as compared to all other catheters, PFA catheters. It's a second generation PFA balloon. It has a balloon in basket design, which has many specific advantages. So the balloon insulates the basket and pushes the energy field outwards, which results in a larger lesion, so a 20% increase in lesion volume, and less collateral damage, less hemolysis. It's an over-the-wire system, so you can have the perfect PV position and the perfect alignment. It's fully integrated into the 3D mapping system. You have a contact assessment, impedance-based contact assessment. And due to the balloon design, you always have the perfect intra-electrode spacing, which is important for lesion formation. And since it's a very powerful balloon and steerable sheath, you can get a very good wall contact. The catheter was approved with the Volt CE mark study. It's a worldwide study where up to 150 patients with paroxysmal persistent AF were enrolled. The primary endpoint was the 7-day safety and acute and 6 months long-term effectiveness. And there was this feasibility sub-study. The study protocol was very detailed, so we had to do a pre-procedural voltage map and pre-procedural phrenic nerve pacing from the right SVC. we had to deliver a minimum of 2 and a maximum of 8 applications, PFA applications per vein. And post-procedure, there was a 20 minutes waiting period. We had to repeat the voltage map and pace the phrenic nerve again. So what were the results? The results of the 6 months follow-up were recently presented at ERA. And basically what we found is that the success rate was 88% for paroxysmal AF and 76% for persistent AF. The acute effectiveness, so PVI confirmed after 20 minutes waiting period, was meant in 99.1 patients. In one patient, he had a pericardial effusion. The vein could not be assessed after 20 minutes waiting period. In total, 17 PFA applications, so 4 per vein, were delivered. And adverse events occurred in 2.7%, so vascular access complications, 1 tamponade, and 1 pneumonia. This happened in our hospital. It was 5 days after the procedure and not procedure related. What I really think is extremely impressive is the durability of the veins. And 7 patients had repeat procedures. In 6 patients, it was remapped. And 19 out of 23 isolated veins remained durable isolating during remapping. And all patients who underwent mapping after the blanking period, the veins were isolated in 14 out of 15 veins. And at our institution, all veins were isolated. Recently, at HRS, the 12 months follow-up was published. It was this 83% success rate for paroxysmal and 58% for persistent AF patient. So what about our workflow? Our initial workflow was that we treated the patient in constant sedation. We did an angiography of the veins. We had no pre-procedural imaging, no CT, no MRI, and we did the pre-procedural HD grid map. Then we paced the catheter in the veins and in the right-sided veins. And if it was, you could capture the right-sided veins, we had to use the low protocol. If not, we used the high protocol and did the remap. And we had a 20 minutes waiting period. That's what the procedure looked like. You see the volt balloon. We always do an ultrasound-guided punctures. You insufflate it with 9 mils of saline and 1 mil of contrast. We do the transeptal puncture and then park the catheter in the left superior vein. Initially, as I said, we had to do a map using the HD grid. You introduce the balloon, and then you're ready to go. But what you can also do, and this is our new workflow, is that you can map with the balloon the left atrium. So the second phase was that we mapped with the balloon the left atrium and then started with the application. And you isolate the vein, pull back, rotate, and do a second application. And initially and then we go to the right-sided vein, as you can nicely see. And this is what you also know, whenever you deliver current, the electrograms disappear. By the way, the blue bars indicate that more than 2/3 of the electrodes are in contact with tissue. So this is the right inferior vein. And after the procedure, we always repeated the map with the volt balloon. So what about our initial experience? We treated, so this is the summary of our first 40 patients, 30 within the study and 10 outside the study. Procedure duration was 71 minutes. Fluoroscopy was 9 minutes. I think what is really interesting is that there was only little sign of hemolysis, and there is a significant difference as compared to the FARPULS technology. So there was no change in the GFR as compared, we also compared the data with the FARPULS technology, where you can monitor a decline in the GFR. What about the acute effectiveness? We could isolate all pulmonary veins, had 1 pneumonia 5 days after the procedure. The patient was re-hospitalized and no other complication occurred. What about our new workflow? Our new workflow is a more effective workflow, so we didn't do the pre-HG grid map and the post-HG grid map, and just take a map on the fly and did the post-ablation map, a very brief map with the volt catheter. We just changed now recently. We just did this new series with minimal sedation where we did the procedure even with the patient awake. So that the Volt procedure I did this morning, I could continuously speak to the patient. He was not sleeping. We only used midazolam and fentanyl. And that's what it looks like. I think this is really unique. So we started with the left superior PV, immediately balance the system and isolate. That's the workflow that you know from other balloon technologies. So we don't take any pre-procedural imaging anymore. Blue means that, again, 2/3 of the electrodes are in contact. You rotate the balloon and deliver the energy. After the superior, we go to the inferior. And as you see, we only take geometry on the fly. We want to see, is there a low voltage or no low voltage? And if there is a low voltage in persistent effect, we see we isolate the posterior wall. What you can nicely see is how I just moved to the right inferior vein. I isolated the right inferior vein, rotate the balloon, and give a bonus application, and then go up to the right superior PV and isolate the superior PV. We always space the phrenic nerve, and if we capture, we use the low protocol. If we do not capture, we use the high protocol. Low protocol means 3 applications with less energy. Then we go to the posterior wall. You see it's a low voltage area, and if there is a low voltage, we would isolate the posterior wall. You can deselect the splines of the anterior wall. I think this is also a huge advantage. So the electrodes which are in contact deliver energy, and the electrodes which are facing towards the anterior wall, we can just simply deselect. And with an additional 4 application, you can easily isolate the posterior wall. So this is our standard. Usually it's 4 application for the posterior wall. We do a quick remap and you see there is only, everything is isolated. So very impressive workflow and very fast workflow. What about the new workflow? This is also including the learning curve of a second operator. And we had a mean procedure time of 38 minutes. The procedure today was 29 minutes. So it's even getting more efficient. And we used a mean of 4 applications. So that I would like to come to my conclusions. The Volt CE mark study, it demonstrates that the Volt PFA, it's a safe and effective for the treatment of paroxysmal and persistent AF. The balloon in basket PFA combines the benefit of the balloon design, wall contact, less hemolysis, safety, the PFA energy, and the 3D map. Conscious sedation has similar results as general anesthesia. And as you can see, there are hardly any muscle contractions. And you can even perform this procedure with a patient who is awake. A simplified workflow facilitates an easy and secure PVI. And the posterior wall isolation seems to be feasible easily. So that's why I say the balloon, it's back on stage. And the future of the balloon, it's bright. Thank you very much.
Is there any question for Roland? We will have another opportunity later on because there will be a live case from Lübeck. So
perfect. Yes.
We're waiting for the microphone.
One question, so you can answer. Okay.
I have a question about anesthesia protocol.
Yes.
What's your, in your opinion, the best way to this protocol?
Yeah. So our standard in Lübeck was fentanyl, midazolam, and propofol for all procedures that we had. But there is a need to do procedures even without deep sedation, without propofol in many countries around the world. So we evaluate currently a workflow with the patient awake. And we did a few patients now with midazolam and fentanyl. We could continuously speak to the patient and ask them, so would you do the procedure again awake, or would you want to sleep? And the patients that we treated so far, they say, no, I'm perfectly fine. I think that's a procedure that you can easily conduct awake. And I think this is just unique for PFA technology. So it has so little contraction and obviously pain that you can do it even awake. We are still working on the optimal analgesia, but at least midazolam, fentanyl works, and we now added a lidocaine as well.
Okay, thank you very much. And I think we will reconnect later for the live case. So there will be still room for any questions or comments. Okay, thank you, Roland.
Thank you so much. See you later.
See you. So now we will connect to Split. I see already Ante Anic, and he will give us his presentation.
Good. Hello, everyone from Split. I see that you see my screen, and let me start. Today, my topic is to cover QuickShot Nav catheter. It's a large area, large focal PFA system from CardioFocus. And it's really 10 millimeter form catheter structure. It has integrated magnetic sensor. And when you ablate, it's unipolar ablation, so monopolar ablation. You ablate from the whole catheter structure. However, there is a part that is insulated, so to push the energy over there and not to expose the whole volume of the blood around the catheter to a PFA. Throughout the procedure, we exclusively use 2 mils per minute at all time. So this tells you how sure are we at a thermal footprint and thermal signature of this platform. What about PFA dosing? Currently, there are 2 doses, two options, both again in monopolar fashion. One lasts 7 seconds. We call it nominal dose, QS dose. In very near future, this is going to be it's going to take 5 seconds. And we have so-called QS plus dose, where we compress double the energy to get 20% extra depth. And that currently takes around 10 seconds. In a few months, we'll start doing with a generator that can deliver that in 7 seconds, again, with the same heat signature. We tested both in deep sedation and general anesthesia. Today, we're going to show you a live case in deep sedation. And trust me, doing deep sedation, PFA, is something, a completely different environment than, especially when it's doing with focal, than compared to GA. And mostly we did asynchronously. If you want to do synchronously, you can do it, but we do it asynchronously. This is why we are fast. It comes with proprietary detection mechanism, counter detection. It's based on local impedance. Yeah, I think you're aware of this concept by now. And on top of giving you different delta, and we try to stratify it by the different shades of the green. A light green means a great delta impedance between blood pool and tissue, and gives probably pretty much good appreciation of the contact. And so it's also important to understand that the catheter is very flexible. This is flexible night and all. I think it's pretty much piece of mechanical engineering art. And you see here how flexible, and it absorbs well the heart motion. When I talk about any platform, when we talk about depth, I'm always interested to ask you, well, okay, for that depth, are you sure that you have any thermal footprint? For here, this is way one PF configuration, the one that we are using for years with Centauri PFA generator, and connected our focal catheters. And you see here that there are no microbubbles, and QS dose can drive you above 7 millimeters in depth, and it's very wide at the surface. However, this is very important to know how do you drive this lesion tag size. What we have published and presented at HRS 2 years ago is for initial experience from 2023 is telling us in animal lab, as soon as you have some contact, it's a very flexible tip design. As soon as you have some contact, we call it some tissue coupling, you have almost the same geometry of the lesion compared to when you have high contact, high tissue coupling. Again, this owes to the very flexible design. Here you see, and we'll present this today in a live case, this contact feedback. It is important. I've witnessed Massimo Garibaldi's lecture yesterday. He really did a lot of talk on a thermal footprint. This is a worst case scenario with this platform. So QuickShot catheter, 4 times the nominal dose. And you see that whereas at 3 millimeters or 7 millimeters, it does not reach the thermal necrosis threshold. This is very important. So QuickAF is a trial that we started 2 years ago. So it was a phase 1 in 2023 with 20 patients, and then company went to transition. It took time for the asset to make transition from the Galvanize or Galaxy to the cardiac focus, and now we are continuing this development. Initially, we did 20 patients. It was PVI only approach, and it was dose optimization. We had basically remap, and now we are doing next phase for the persistent patients. PVI plus will show you and complete assessments of safety and effectiveness. This is how it looks on a mapping system. Usually we do it with the arrhythmia system, with the EasyPulz system. So again, it is not seamlessly integrated. It has magnetic sensors, so with some few help of good people from companies, it can really be fully integrated. But for now, we tested also the mapping capabilities. You see the catheter is visualized like a small laser catheter. This is how it looks currently on arrhythmia, and this is what you're going to see today. So this is the previous map was done. The previous shell was taken with the Orion catheter, and now we are taking the same shell just to prove that it just takes more time, but you definitely get the same geometry. And then the ablation, we take dots manually. It's not integrated. The catheter visualization is lost during pulse field ablation. It comes immediately after PFA has been delivered, and we do typical WACAs. Again, here you have a show. Here showing how we are remapping post WACA, post PVI. We are remapping. In this case, it was pretty much we used 10 millimeter tag. It took 16 minutes for a PVI. Cohort 1 in this first phase in 2023, we really did it without contact detection. And then in the second group of 10 patients, we started to understand this impedance-based contact system. So it was 20 patients done in deep sedation, absolutely free of any serious adverse event. However, our chronic durability was not perfect, because only in last five patients we really find the contact assessment, and contact is important. It was the most important. We knew that before, but this was the most important takeaway. When you're doing something with a focal ablation, you have to have contact. And of course, that chronic PVI durability improved with a better contact understanding, contact feedback. So this is where currently we are. In 2025, we already performed another set of 10 cases in this phase 2 of QuickShot study using improved contact detection system, what we have learned in 2023. And now we are testing it for beyond PVI. We are doing posterior isolation, the box lesion, CTI in everybody. In several patients, we'll do also the mitral. Again, it will be checked with remap, and of course paying utmost attention to safety, to stay without thermal footprint, without problems. So 10 patients, we did a few patients in deep sedation this April, and 6 patients in general anesthesia. Procedures are also followed and guided by ICE. About safety, we had one young male patient. He was 55. 6 days after a procedure, he had TIA. Symptoms lasted for 10-15 minutes, fully resolved. But for this thing, I tell you, and I can tease you, that the next year on symposia like this, we're going to be talking about spurious and various mechanisms of stroke after pulse field ablation. In this patient, we had MRI that was negative. So in this patient, post-procedural MRI was negative. So it was not immediately intra-procedural. It was something happening 5 or 6 days after. This is something that you will be seeing. Talking about efficacy, well, in all patients, we could do all lesion sets exclusively with the investigational catheter. PVI times around 30-35 minutes usually. CTI is fast. For the posterior wall, it takes 8 to 10 minutes. You'll see today in a live case. The next step for this technology is a pivotal trial. We think that right now it's ready for the pivotal trial because this impedance-based feedback is really improved. It works when we assess it with the ICE. I think it's very reliable, and it's going to drive the success for this technology. On top, there is a new so-called cardiac wave generator that really integrates all this QS plus dose, and it's going to be like 7-second delivery for 7.5 or 8 millimeter depth, absolutely free of thermal footprint. That's something we need on our market. So with this, I conclude this part. I'm waiting your questions if you might have one, and we'll connect soon with the live case.
So thank you, Ante. Are there any burning questions? I would have one before others. You said there's a magnetic sensor on board of the catheter, and it was used in the, what you shown in Opal system, but is it used really, or is it impedance-based, or is it ready for some other integration?
Yeah, so Peter, thank you for the question. As I stated before, it's just a matter of the goodwill of the companies whose system it is. So let's say for a Boston Scientific or Abbott, it will probably take 2 or 3 days to seamlessly integrate this system. 2 things are underway. We are in contact with Abbott, and probably in June we'll start doing cases with fully integrated system with a Navic system. And the next step is in September we're gonna start doing QuickShot cases with the LumaVision system. It's essentially it's an ICE platform that generates 3D geometry and immediately incorporates a magnetic sensor principal system. So it's gonna be very fun to have this 2 technologies married together. It's gonna come probably in September of the first cases. Currently, it's on impedance.
Okay, that makes a lot of sense. Thank you for the answer and kind of revealing what's coming. So, any other questions that might be? Okay, so thank you very much, and see you soon. Huh?
Thank you. Bye-bye.
Bye.
We can come back to Homolka only for a few minutes to finish the case or update the case. I heard that they already finished. Můžeme se spojit na Homolku ještě? Je to domluvený, že jenom ukážou, co udělali.
Co? Ne, nechci.
Honzo?
Hello guys, do you hear me?
Yeah.
Yeah, are we back? Okay. So thank you to show the result of this quick case finally. Patient is already extubated and transferred to intensive care unit. So I hope you see the AFARA screen. So finally you saw during the procedure how fast it was, how straightforward. And finally we did just application during the live case. We didn't do any additional application after, or maybe we did, just 2 PF applications, like to add, to get maybe more transmural. So you see that it was finally the focal tachycardia from LVOT. So you were right, because when I saw the image from on intracardiac echo, we maybe could do it also from right ventricular outflow tract. So patient after these applications, we didn't, he wasn't inducible, even with 2 extra stimuli. So I think that finally it was very straightforward and successful. Yeah, that's my summary of this case.
So you believe that this was focal mechanism with this?
I think it's hard to say
potential
from map.
Well, of course, without entrainment, it's very difficult to say.
Maybe can we see also the voltage map? Just I know it's maybe
so there
mapped
is some
fully,
kind of,
but maybe the voltage map would be. And if you hide the ablation tags, just to have an idea.
Yeah. So this is the voltage. So can be maybe because of this voltage reduction here. Of course, can be some kind of micro reentry, but we didn't have time to map it more deeply.
Mechanism, but you were lucky that you hit the channel.
Yeah, we did it. Okay. So.
And there is no problem with conduction.
So it was trouble with conduction even before. Now there is a RBBB. So, but still have to be paced. So, and the plan is to add to upgrade for CRTD. So that's
what we discussed already.
Yeah. Okay.
Any questions? If not, thank you very much for this
Thanks
update.
A lot. Thank you. Super. Thank you. Bye-bye.
Yeah, bye.